And okay, so welcome everyone to the fourth installment today of the renal pathology patient webinar series. So the focus of today's session is the pathology of diabetic nephropathy. So just as an introduction, as a reminder for those that may not have been able to attend previous webinars in this series, the RPS is a nonprofit organization committed to the improvement and dissemination of knowledge regarding the pathology and pathophysiology of kidney disease. The RPS promotes excellence in diagnosis, fosters basic clinical and translational research, and encourages training and education in renal disease. The RPS also sponsors international conferences and symposia and brings news and updates pertaining to renal pathology to its members around the world. So the goal of this patient webinar series is to further support interactions between pathologists and patients with kidney disease by providing patient-centered educational content focusing on the basics of renal pathology and common kidney diseases. So through this series, the RPS hopes to empower patients and pathologists alike and thus work towards minimizing the burden of kidney disease around the world. And I'd like to acknowledge that this series is supported by an educational grant from Travere Therapeutics, and we're very grateful for their support. So just a couple of quick housekeeping items before I introduce our speaker for today. So if you have any questions during the presentation, please enter them into the chat, and then we should have plenty of time at the end to address them. And then after the session, all attendees should be receiving an invitation to complete a short SurveyMonkey poll to collect your feedback and help us improve future webinars. So please watch your emails for that. Okay, so without further ado, it is my great pleasure to introduce Dr. Neeraja Kambham, who will be giving today's webinar titled The Pathology of Diabetic Nephropathy. Dr. Kambham completed her anatomical pathology residency training and medical renal pathology fellowship training at Columbia University in New York. And also did a surgical pathology fellowship at Stanford University. She's now a professor of pathology at Stanford University, where she's also the director of the Renal Pathology and Electron Microscopy Laboratories and director of the Renal Pathology Fellowship Program. So thank you again, Dr. Kambham, for being with us here today, and I will pass it over to you.
Thank you, Dr. Adam. Good morning, or I guess for some of you, it's good afternoon, everyone. I really thank Renal Pathology Society for giving me an opportunity to have a patient-centric discussion about diabetic nephropathy and its pathology. So without much further ado, so I will move on to the talk here. So as you all know, the burden of chronic kidney disease is quite heavy in our patient population. And clearly, if you look at the CDC data here, in people over 65 years of age, the burden of chronic kidney disease is about 38%. So it's pretty high, and it seems to be the case across all race and ethnic groups, perhaps more in African Americans, non-Hispanic African Americans. So when you look at the causes of chronic kidney disease and especially the end stage kidney disease, diabetes comes up very prominently. Almost 40% of the disease burden due to end-stage kidney disease is due to diabetes. And a lot of these patients with diabetes mellitus also have other comorbidities like hypertension and so on. Combined, you can see the disease burden is extremely high. And when you think about diabetes, there are, as you all know, there is type 1 and type 2. Type 1 constitutes about 5 to 6% of all diabetes mellitus. And so vast majority of this disease burden is due to type 2. So having said that, so this is actually a single center study from University of Northern California, sorry, University of UNC, not Chapel Hill. And you can see that they have looked at their biopsy data, kidney biopsy data, and looked at the frequency of each biopsy diagnosis of glomerular disease, and that has spanned over 3 decades. And you can see that there are, so let's just focus on diabetic nephropathy, and that's the green line here. And you can see that over a period of, over the period of 3 decades, the prevalence of the diagnosis of diabetic glomerulosclerosis has increased fourfold in adults over 18 years of age. And the UNC Chapel Hill Center, the referral population is from southeastern United States. So it's really has been dramatically increasing. And this study focuses on all the modifiable risk factors like the patient's glycemic control or hypertension and other comorbidities, indicating that a lot of this burden is probably related to risk factors which could be modified. So that's actually encouraging. And they also looked at the frequency of this biopsy diagnosis according to the age of the patient. So here you have in the graph that there are patients who are from 0 to 9 years and 10-year increments and greater than 79 years of age. And you can see overall, and again, our green line here, the diabetic glomerulosclerosis has really increased across all age groups over time. And vast majority of this diabetic glomerulosclerosis, if patients have what's called the nephrotic presentation, and you can see that here, that's the nephrotic presentation, indicating that all of them have this really high degree of proteinuria, that is a lot of protein being spilled in the urine, more than 3.5 grams. So that, and very few of them have what's called the nephritic presentation. That would be, again, a dotted green line here, a nephritic presentation indicating that there is a lot of hematuria and renal insufficiency associated with hematuria or blood in the urine. So, so diabetic glomerulosclerosis, clearly there is ample evidence that it has been increasing in frequency. So we talked about diabetic nephropathy being a very common cause of chronic kidney disease, and the patients often have complications due to diabetic nephropathy, and they have hypertension, cardiovascular risk goes up, and patient stroke risk goes up with the presence of CKD and so on. We talked about the type 1 and type 2, and the comorbidities seem to be more common in type 2. Right? And what is the incidence, prevalence and incidence of diabetic nephropathy when a patient has type 1 or type 2? And it's kind of similar, but because of the high prevalence of type 2 diabetes, most of the biopsies we review are due to diabetic nephropathy in type 2 diabetes. The incidence of diabetic nephropathy increases with the duration of diabetes mellitus. So the overt diabetic nephropathy probably develops about 10 to 5 years of type 1 diabetes, and probably shorter duration, 5 to 10 years for type 2. And the reason the difference is because type 1, we have a known starting point when the patient developed diabetes, whereas in type 2, it is a very insidious process, and the patient may have undiagnosed subclinical diabetes mellitus for many years. So we don't know the exact starting point for type 2 diabetes. But if you were to take type 1, it takes about 10-15 years of having diabetes to develop diabetic nephropathy. There are also some racial ethnic factors. Clearly, the diabetic nephropathy is more severe, and the progression is more higher in African American patients, Latinos, and American Indians. In African Americans, probably some of the progression may be related to ApoL1 genotype. Again, we won't discuss all that. It's not the focus of the topic today. There are familial predisposition for developing diabetic nephropathy also. Glycemic control comes up very high as the predisposing factor for developing diabetic nephropathy, that is poor glycemic control. And of course, the comorbidities also add to the progression of the disease. So when we get a biopsy, a renal pathologist gets a biopsy of biopsy in a patient with diabetes mellitus and we are thinking about diabetic nephropathy, there are a few things we are really looking out for in the clinical history given by your nephrologist. One is duration of diabetes mellitus, how is the glycemic control, what is the hemoglobin A1C now and in the past, comorbidities, presence or absence of diabetic retinopathy. There is a close correlation between the diabetic nephropathy and retinopathy. So if the patient has diabetic retinopathy, then our suspicion of diabetic nephropathy goes up. Proteinuria, quantification of proteinuria is something we pay attention to. It can be measured either as a spot urine or a 24-hour urine collection. Typically, these patients with diabetic nephropathy have nephrotic proteinuria that's more than 3.5 grams in 24-hour collection. And then we also look for any microscopic hematuria. It's microscopic is only on urine dipstick. They saw some blood in the urine. And it's present in about 50% of the patients, but typically it's mild and there shouldn't be any distorted or dysmorphic red blood cells or red blood cell casts in a typical diabetic nephropathy on urine microscopy. But when they are present, we are thinking about alternate diagnoses or a superimposed process. Increased serum creatinine, again, we like to know what is the rate of deterioration, that is how rapidly has the serum creatinine gone up. That helps us in our differential diagnosis. And of course, we look at the serological studies like various antibodies, ANA, ANCA, C3, C4, and all of those are also given to us and we take that into account and any other significant history. So what do we see in diabetic nephropathy? So this is one of the classic features that we see in pathology on a kidney biopsy. This is what we call light microscopy, and the stain you're seeing here on the screen is called a PAS stain, which highlights the fibrotic areas and the basement membranes in bright pink color. So what you're seeing here is a glomerulus, which is clearly much larger than normal. And there is all this material, this pink material here in the mesangium, and that is causing the expansion of the mesangium. Sometimes this mesangial sclerosis, we call it sclerosis because it's staining properties will help us determine. And the mesangial sclerosis can be like diffusely present in all the mesangial areas, or sometimes it can have this nodularity where the center portion of it is acellular and all the nuclei, which are blue in color, are pushed to the edges. That's called the nodular mesangial sclerosis. And we'll talk about it in a minute. This is also a classic KW nodule or Kimmelstein-Wilson nodule. So that's the mesangial changes that we see. And in addition, we will see the basement membrane thickening. Okay, so that's another feature we see. So the glomerular capillary loops, this is the mesangium and all the capillary loops are kind of compressed on the edges here. And this line here is the glomerular basement membrane, and this is clearly thickened. And compared to normal, it should be about 4 or 5 times thick before we can actually appreciate it on light microscopy. And not just the glomerular basement membranes, these are tubules here. So that's the glomerulus, and this is a Bowman's capsule. And if you see here, you can see that the proximal tubules are here, and the tubular basement membrane is also thickened. And the other feature we look for is hyaline material in the arterioles, affecting both afferent and different arterioles. But that's and I will show you some images of that. So this is like the classic feature that we are seeing on diabetic nephropathy. However, this is not how it starts. So there are changes that are seen in the glomerulus prior to developing these classic features. So this is a pathological classification of diabetic nephropathy. It was put forth by the Research Committee of Renal Pathology Society, and this has been published for over 10 years now. And the change is the earliest change that we see in a patient when the patient develops diabetic nephropathy is thickening of the glomerular basement membrane. GBM stands for glomerular basement membrane. The thickening and how do we determine thickening? You can see it on light microscopy, but the earliest changes are seen on electron microscopy, and we look at the thickening of the size, and everyone, the patient, the adult thickening is reached by about 9 years of age. Anyway, so that's the GBM thickening. And then as the diabetic nephropathy progresses, start seeing mesangial expansion we saw earlier. And if the mesangial expansion, depending upon whether it's it's compressing the capillary loop and narrowing the capillary loop, you can call it a 2A, and progresses to 2B. And once you start seeing the nodular mesangial sclerosis, you would call it a 3. And as it progresses, it becomes the advanced diabetic nephropathy, where in addition to the glomerular changes of diabetic nephropathy, there is a lot of global glomerular sclerosis and involving more than 50% of the glomeruli. So this is the glomerular classification of diabetic nephropathy. But we also pay attention to the interstitium and blood vessels. So the interstitial lesions that are assessed are the amount of tubular atrophy and interstitial fibrosis. We call it IFTA, basically interstitial fibrosis and tubular atrophy. So that's the short abbreviation for our tubular changes. And depending upon how much of this changes, chronic changes are seen in the biopsy cortex, we give it a score. And then there is associated interstitial inflammation. We try to see where the inflammation is, the areas of atrophy or not. And the other feature we're looking for is the blood vessels, looking at the arterioles, how many arterioles have this hyaline material. And then we also look at the larger caliber arteries, if there is intimal thickening, and what's the degree of intimal and medial thickening and so forth. So let's look at some of the glomerular changes that we expect to see as the diabetic nephropathy is progressing. So the earliest change is GBM thickening, as I've told you. So I guess this is a glomerular sphere here with diffusely thickened glomerular basement membranes. And I just put a normal for comparison. I know it's not at the same magnification, but you can see that the glomerular basement membranes are severely thickened, and so are the tubular basement membranes here, okay? And then, so again, you see another view of the tubular basement membranes, which are diffusely thickened in diabetic nephropathy. In this particular case, the glomerulus is already starting to show some increase in the mesangial matrix. There's this pink material there. And we also review the electron microscopy here in the right. For orientation purposes, this line here you're seeing is the glomerular basement membrane, and this is the mesangial matrix, which is increased. So all of these changes will indicate to us that is a very early diabetic nephropathy. And then as it progresses, as you're starting to see more mesangial expansion. So you haven't seen a stain of, this is a JMS stain, Jones methenamine silver stain, again highlights the areas of fibrosis and highlights the basement membranes. You're starting to see that the mesangial area, this black stuff, is all increasing in it's increasing in deposition of mesangial matrix is increasing. And this is a PAS stain. You have seen it before, similar colors, again, mesangial sclerosis and proliferation is going up. I also want to point out, as all of these changes are happening, the tubular interstitium and blood vessels are getting affected too. And here you can see an arteriole near the vascular pole. This pale material is the hyaline that we'll talk about in a minute. And the hyaline seems to be affecting a bunch of branches of the arterioles near the vascular pole. So this is the next stage. And then the further stage is you're starting to see more nodularity in the mesangial areas, okay? Mesangial sclerosis, and this is a silver stain. We've seen a stain like this before. And here is a very well-developed acellular nodule of Kimmel-Steen-Wilson nodule here. Okay. And as the progression of the glomerular changes is happening, there tends to be injury to the lungs. the cells which are lining the capillary loops, the podocytes, and eventually they tend to have some sclerosis, segmental sclerosis, where parts of the glomerulus are kind of adhesed to the Bowman's capsule. So that's part of progression of the glomerulosclerosis you will see. And here on the rightmost panel here, you will see that the tubulointerstitial changes. These tubules are no longer well preserved. So the diameter of the tubule is less than 50% of the normal, and the tubular basement membranes are thickened, and some insudative material kind of is extending along the tubular basement membrane as well. So there's a lot of tubular atrophy and fibrosis with all these blue dots in between the interstitial inflammation associated with that. And at the bottom of the screen is an artery here, and you can see that the lumen of the artery is narrowed by this intimal sclerosis that is happening. So all of these changes affecting multiple compartments of the kidney parenchyma. And then as it reaches towards the end stage, you will see that all these glomeruli are completely sclerosed. That is, it just looks like this hyaline material there, but there are no patent capillary loops for the glomerulus to function, do its job. And the tubular atrophy and interstitial fibrosis. So interstitial fibrosis is the space between the tubules are really expanded, and all this fibrous material is deposited. Okay, so and then this is a trichrome stain, which this is the first one you're seeing. Here you're seeing a spectrum of changes. There is a glomerulus at the top here. You're seeing mesangial nodularity and sclerosis. The one at the bottom is completely sclerosed. There are no patent capillary loops. And you can see normally all of these tubules should be back to back, and they're all further away from each other. High power view of this one of this glomerulus, globally sclerosed glomerulus. And you can see it is completely sclerosed, but you can see the outlines of nodular sclerosis there. So you know the patient had diabetic nodular sclerosis before this progression. And you can, all this hyaline material, these are texturally different from fibrosis. These are basically, hyaline is plasma insudation that happens associated with the injury. And in this particular case, it's right next to the glomerular basement membrane. It's a term that's used is fibrin cap. But this is like getting towards the end stage kidney. So other terminologies that we see, you might come across in our biopsy that we put forth, that is insudative lesions, where the insudation of plasma proteins. It can be fibrin caps in the glomerulus we talked about, or capsular drops. Capsular drops is where the similar insudative material is kind of tracking along the Bowman's capsule. Here is a glomerulus with mesangial sclerosis, and this pink material is hyaline is tracking through. And then you can have arteriolar hyaline here. Here is a glomerulus with some mesangial sclerosis, diabetic nephropathy changes. And this is a longitudinal section of an arteriole, has all this really bulky, pale material causing narrowing of the lumen. So that's arteriolar hyaline. So these are all insudative lesions that we discuss in the biopsy. Other terms that we use is microaneurysms and mesangiolisis. Basically, here is a glomerulus with Kimmelstein-Wilson nodules. They are nodular glomerulosclerosis. So as there is increased matrix getting deposited in the glomerulus, the body is trying to get rid of the matrix because it's trying to preserve the glomerulus. And there's a lot of enzymes, metalloproteinases they're called, they start breaking up the matrix. And that's what is happening at the edges of the nodule. It's breaking up into fragments. And so that results in the confluence of all the capillary loops filling together, forming what's called a microaneurysm. Okay, so here all these outlines you're seeing are the RBCs kind of stuck in the mesangiolisis, and you can see that you can form microaneurysms. Again, these are all the features you might see in the report. And sometimes the segmental sclerosis is very prominent. This is a biopsy which had this glomerulus seems has some changes, mesangial sclerosis, but this glomerulus in addition seems to have this segmental sclerosis. And on high power at a different area, there are some foam cells and hyaline inundation, and these are all epithelial cells called the podocytes. They're undergoing hypertrophy. So these are all the changes you can see. And this would be called FSGS, that is focal segmental glomerulosclerosis. This is something when we see active lesions, we describe it. It may have prognostic implication. So here is an arteriole right next to the glomerulus, again has hyalinosis in it. And on the left, you can see this part of the proximal tubules, the tubulointerstitial compartment is preserved, but this has more tubular atrophy and fibrosis. Okay. This is another view of similar changes, again, showing a lot of podocyte hypertrophy and hyperplasia, all these cells with globules in them. So this is high FSGS lesions in a patient with diabetic nephropathy. So those are all the light microscopy features that we see. And if you have attended one of the earlier sessions, all of the kidney biopsies are assessed by light microscopy, immunofluorescence, and electron microscopy. So this is a immunofluorescence microscopy image. So in a bona fide diabetic nephropathy without any other superimposed processes, the immunofluorescence is negative. So when we say negative, that means there are no immune complex type deposits. But what you can see is sometimes with IgG, or almost always with IgG and albumin, you will see that there is some linear staining along all the basement membranes, glomerular and tubular basement membranes. So this is actually a helpful feature for us. There is no correlation with the severity of lesion. And the only other thing we might see is some IgM and C3 in areas if there is segmental sclerosis, but otherwise it should be completely negative. So this is something you would see and is helpful. And then we do the third component we do is electron microscopy. And the electron microscopy, you've seen a similar image before. This is like a very high power view of a few capillary loops. This, I would say, is a portion of a glomerulus, perhaps just like 5% of the glomerulus on one edge is taken. And so for orientation purposes, this is the mesangial sclerosis area. The pink material we saw on PAS10, that's the mesangial sclerosis. Here it's milder degree, whereas on the right, it's really very prominent, pushing the capillary loop to the side. And then, so that's the mesangial sclerosis. And then you have the glomerular basement membranes are diffusely thickened there. Again, this is by experience. We know it's thickened, but we also, on a typical case, we measured the glomerular basement membranes. But important thing here is that there are no immune complex type deposits. So we know that in this particular instance, it's all diabetic nephropathy. That's the GBM thickening, the arrows. Okay, so going back to the pathological classification of diabetic nephropathy, how are we using it? So the actual classification uses glomerular lesion, but we know that we do score the tubulointerstitial and vascular compartment. So the earlier studies showed that it showed the value of the diabetic nephropathy classification, but subsequent studies, it's not very clear how there are some large European and US studies, especially US studies are ethnically diverse populations involved, and these large cohorts show that the diabetic classification is not predictive of time to end stage kidney. But one thing that is predictive is that the tubular atrophy and interstitial fibrosis is an independent predictor of renal survival. So, so I think the tubulointerstitial compartment seems to be the more important compartment. So when we do look at a biopsy with diabetic nephropathy, then we are wondering what else could it be? And so there are certain diseases we think about. One of the important thing I want to share is what's called the idiopathic nodular glomerulosclerosis. And this is actually a biopsy from a patient who does not have a clinical diagnosis of diabetic mellitus. And the glomerulus clearly showing the KW nodules, the Kimmel-Steen-Wilson nodules, and mesangial sclerosis there. So so what do you do with this? So in a particular case like that, we talk to the nephrologist and try to, try to see if the patient has subclinical undiagnosed diabetes mellitus. Sometimes if they have hyperglycemia not meeting the criteria of diabetes mellitus, or hyperinsulinemia for prolonged periods of time, they may develop these changes even before they reach the clinical diagnosis of diabetes mellitus. And when all of that is excluded, there is correlation that similar changes can be seen in patients with chronic hypertension and chronic smoking. Smoking seems to be very important reason why the glomerular changes are developing, and they mimic diabetic nephropathy. And there are other things we talk about: light and heavy chain deposition disease, amyloidosis, MPGN, cryogen, and so on. Okay, so we won't really go into it, but I just want to give you one example to see how a renal pathologist thought processes. So this is a biopsy from a patient, and you can see all these mesangial nodules here. You could easily mistake this to be a diabetic nephropathy. But what happens is when we do the other modalities, the immunofluorescence and electron microscopy, you will see that we do a whole bunch of panel, a complete panel of immunofluorescence. And we did that. The linear staining of the glomerular and tubular basement membranes and even arterial basement membranes was there for lambda, but not for kappa in this particular case. So there is a light chain restriction. That's the term we use. So it is having a monoclonal deposition there. So that would rule out diabetic nephropathy. And then when we look at it on electron microscopy, they were actually electron dense deposits. These are all shades of gray, but these are deposits. You have to trust me. These are all deposits, and you can see that there are some powdery deposits along the glomerular basement membrane and also along the tubular basement membrane. So this dark powdery stuff, these are all electron dense deposits, which you wouldn't see in a diabetic nephropathy. So when we look at a biopsy, we are using all three modalities to come up with a diagnosis. So having said that, I'll stop discussing the differential diagnosis at that point. And as a pathologist, we don't just look at the pathology and look at all the lesions and describe the lesions. We are also have a lot of things that are overlaid while we are looking at the case, the clinical history, and also what we think about the pathogenesis of diabetic nephropathy. The two broad things that we think about is hemodynamic factors, that is pressure related factors. And also there are some metabolic factors like hyperglycemia, like prolonged periods of high glucose levels in the blood, and the pressures in the systemic pressures as well as in the glomerulus itself. All of these factors converge and cause the diabetic nephropathy. And the pathways through which it causes, there are lots of things that are studied by people way smarter than me, and it is really helpful in thinking about the future therapies. But the point is that when all of these changes are converging on the glomerulus or any other organ for that matter, there is a lot of intracellular signaling pathways are activated, and there's a lot of pro-inflammatory pathways are activated and pro-fibrotic pathways are activated. So you start seeing all of this increased deposition of this collagen in multiple places that we've already seen images of. Clearly, who develops diabetic nephropathy, there is a genetic susceptibility, and also there may be epigenetic modifications, and the comorbidities, which are modifiable, will also play a role in progression of diabetic nephropathy. So this is just a scheme for you to think about the clinical as well as pathology that we see. So on the left here, so the point here I'm making, say that although we talk about this classification and all the descriptors have shown as a linear, as sequential changes, they're not always linear progression. So there is some overlap that can happen. So in the earliest stage where the GFR is the glomerular filtration rate is normal and there is no albuminuria in the urine, that is there's no protein getting spilled in the urine, at that point the glomerulus is completely normal, but as in the early stages, you also start seeing glomerular hypertrophy. The glomerulus will enlarge in size, and it's a very well-described feature. And then as the diabetes progresses, there are a couple of ways it have increased filtration in the glomerulus. And then after it increases, it starts reducing as the disease progresses. Then the GFR declines to end-stage kidney. On the urine spilling point of view, initially there is microalbuminuria. It's like between 30 to 300 milligrams in 24-hour urine. And then if it's more than 300, that's macroalbuminuria. And around when it gets macroalbuminuria is when people start thinking about overt diabetic nephropathy. And then the protein spillage kind of increases and then becomes nephrotic. So it's clearly known that in the early stages of no albuminuria to micro and macro, there is reversal that can happen. And in terms of pathology that we see in those various stages, so for example, microalbuminuria can be very early diabetic nephropathy with just thickening of the GBMs, but can also show a lot of mesangial sclerosis and proliferation. And as it progresses to macro, you will start seeing more of those changes, and nephrotic proteinuria. By that time, you will see nodular glomerulosclerosis, the classic features. While all these happening, while we are focusing on the glomerular changes, there's increasing glomerulosclerosis and tubular atrophy and interstitial fibrosis as the kidney loses its functions and becomes end-stage kidney. Okay. So this is a schematic from a few years ago where they really talk about, they estimated based on various studies, they estimated how much of those microalbuminuria and macroalbuminuria how it evolves. As you can see, it can reverse, and it's not always a linear progression, especially in the early phases. So as it progresses, of course, the blood pressure and cardiovascular risk disease also increases. So early diabetic nephropathy perhaps is driven by the glomerular changes like the GBM thickening, mesangial sclerosis, podocyte injury, whereas the late progressive diabetic nephropathy is probably driven by the tubulointerstitial changes. And also there is other evidence, molecular evidence that like one of the JAK-STAT pathway is upregulated more in the glomeruli early on and more in the tubulointerstitium in the later on. So I guess, pathology has a value in, this information is based on clinical, but also pathological information derived from the kidney biopsies. So classification of diabetic nephropathy, focusing on the early changes will be very valuable for prognostication, as well as testing of new therapeutics. And there are several molecules are being tested, are in the pipeline, and they're focused on glomerular hyperfiltration, inflammation, and fibrosis. So, and as you can see, this is not an easy task to do. How do you determine the early changes? How can you grade them? But that's something that we are always thinking about, and that's what the pathologists do. They're all thinking about stuff as we are looking at the biopsy. So with whatever we have, what are the prognostic indicators of progression of diabetic nephropathy? Clinical are probably the biggest ones. The amount of proteinuria and hypertension are the two big ones. But from a histological perspective, what can be derived? The tubular atrophy and interstitial fibrosis. And some studies have shown that the FSGS, the focal segmental glomerulosclerosis type of changes, some of the changes may be predictive of progression of diabetic nephropathy. And some of the changes have also, some studies have shown that the amount of GBM thickening might have prognostic information. There are other advanced studies done in the setting of research where they looked at the myofibroblast, these are cells which are precursors to fibrosis when they're present in the glomerulus and the interstitium. or even the interstitial macrophages, how they correlate with the outcome. But that's done, the last two are probably done in the research setting and not in a protein clinical biopsy evaluation. And then when we look at a kidney biopsy in patients with diabetes mellitus, vast majority of patients with diabetes will not undergo kidney biopsy. So what prompts the nephrologist to do a kidney biopsy? There are some indications like sudden onset of proteinuria. So usually there's a progressive increase in proteinuria. If there is a sudden onset of proteinuria, or if there is proteinuria in the absence of retinopathy and neuropathy, if the duration of diabetes is less, especially type 1, if it's less than 5 years, you're really thinking something else is going on. Or if there is acute renal failure or rapid decline in GFR, that's another indication. And in the presence of blood in the urine, if there are dysmorphic RBCs or RBC CAS, or if there are WBC CAS in the urine, or if there is any other systemic disease like systemic lupus erythematosus or other diseases that could also have an effect on the kidney, that's when the patients are undergoing a kidney biopsy. So when we look at a biopsy coming from a patient with diabetes mellitus, we are thinking about 3 categories of diabetic kidney disease. One is the patient has no diabetes, has some other diagnosis, and it's called the non-diabetic renal disease. And the next few slides, I'm going to say NDRD as an abbreviation. And a subset, about a third of them, will have a diabetic nephropathy plus this NDRD, and some of them have just diabetic nephropathy alone. So this is one of the big studies from US population. And there were a large group of patients, and here I'm focusing on only a subset who had no diabetic nephropathy and some who had diabetic nephropathy and plus non-diabetic renal disease. One of the common things we see in association with diabetic nephropathy is ATN, acute tubular necrosis. That seems to be fairly commonly seen. Some of them have acute interstitial nephritis, and then FSGS is also highly prevalent when there is no diabetic nephropathy, but in that particular instance is because of like a lot of comorbidities like hypertension and so on. So several other things that we will not delve into, that's not the purpose of the talk, but I wanted to highlight that ATN seems to be fairly common in patients with diabetic nephropathy. Some of the themes that have come through from that study, as well as some other studies done in various countries, is that the practice of biopsy indication, it differs in various countries. And the infection rate, prevalence of infections, and geographic differences kind of have an impact on the type of things that you see in the kidney biopsy. FSGS, like I said, is mostly related to hypertension and obesity. Perhaps in some countries, the diagnosis of acute interstitial nephritis seems more common. And I think it's, again, definition of acute interstitial nephritis depends. ATN is very common. And another thing is that the glomerular diseases unrelated to diabetes are often seen in isolation rather than with concurrent diabetic nephropathy. So anyway, I'll just go over a few more slides on this. So you can have, this is a case where there is severe acute tubular injury that is seen here. And here it's a comparison of the slide. You can see that the tubular basement, tubular epithelial cells should be fairly thick, whereas here they are attenuated and they're completely lost and shed in the urine. So that's an acute tubular injury. And it's actually, like I said, very common in patients with diabetic nephropathy, is perhaps reduced renal reserve, and there's a potential for hypoperfusion, and hemodynamics are not normal. And so this is actually is being shown in some of the studies as well. Okay. And then having this acute kidney injury, repeated episodes of it, has an impact on progression of kidney disease. And that's the point of this graph. We don't need to delve into it. It's just that when they have more than, AKI stands for acute kidney injury. And as it increases the number of times they tend to have higher degree of chronic kidney disease. And occasionally you can see interstitial neutrophil eosinophils here. These are the interstitial areas with these bright cells with these are interstitial eosinophils, and they don't necessarily they're not always associated with drug-induced interstitial nephritis. It's not a drug allergy. So you have to be careful about trying to, maybe there are some studies which are showing that these interstitial eosinophilic aggregates may be associated with severity of tubular atrophy and interstitial fibrosis. So I think the key is not to overdiagnose interstitial nephritis, especially if the clinical history doesn't fit. So that was the point. And occasionally we will see neutrophils in the kidney biopsy. So here is the interstitial area, and that's a tubule, that's a hyaline cast in a tubule. And you see a cluster of neutrophils in a tubule. And down here is another tubule, which is kind of expanded by these cells. They have multilobated nuclei. These are neutrophils. When you see that, that makes us think about acute pyelonephritis, that is bacterial infection of the kidney itself, which is, in the presence of diabetes, there is a high propensity to develop infections. So at that point, we talk to the nephrologist and recommend correlation with cultures and imaging studies as needed. Okay. So what are the other non-diabetic glomerular diseases seen in diabetic patients? So this is fairly common, as I've shown you in some of the studies. Almost a third of the patients biopsied for diabetes patients biopsied can have non-diabetic glomerular disease. And so some of the diseases we look for have been reported and often seen are minimal change disease, FSGS, membranous, IgA, and infection-associated GN. IgA dominant is a big one. So just to give you an example, this is a biopsy from an older African-American gentleman and had this diabetes for a while, but is very well controlled, does not have diabetic nephropathy. Already we are thinking, okay, maybe this is not all due to diabetes, diabetic nephropathy. And he had a heavy proteinuria, over 9 grams of proteinuria. And you can see the biopsy, there is some mesangial sclerosis here. And but the important thing, the IF was negative, but on the EM, there is this podocytes are all diffusely effaced. So in this particular case, we diagnosed the patient has minimal change disease on top of early diabetic nephropathy. And that's important information for the nephrologist, because then they can give immunosuppressive therapy and try to reduce the proteinuria. Okay. Another example is another patient who had, again, similar presentation with a lot of proteinuria, but duration of diabetes wasn't that high. And the biopsy showed mesangial sclerosis and really thickened basement membranes. Again, doesn't help you, but on silver stain on, you can see this basement membrane spikes. We get excited when we see that, when we are able to see that on light microscopy. And on IF and EM, the other two things that we keep in mind, there were immune complex deposits. These are all granular deposits in the capillary wall. And on EM, we had this electron dense deposits in the subepithelium. So this was a case of a patient with early diabetic nephropathy, but also had membranous nephropathy. Similarly, the treatment options are different. So this is an important thing to differentiate for us. Sometimes may have diabetic nephropathy, but something else like an IgA nephropathy. This is a biopsy of patient with, again, diabetes and hypertension, had hematuria. Again, diabetic nephropathy can result in mild hematuria, but there were like low titer antibodies. In this particular case, they were not relevant, but they were there, and that prompted the biopsy in this patient. You can see that mesangial sclerosis here, again, some ATN, acute tubular injury here in the tubules. And on IF had IgA deposits in the mesangium. And you can see here mesangial sclerosis like you expect in a diabetic nephropathy, but there were also electron dense deposits. These correspond to the IgA deposits. So this is a patient with diabetes with underlying IgA nephropathy. So when we see IgA deposits in diabetic nephropathy, there's another entity, very important entity we think about is IgA dominant infection-associated GN. So this is an example of a 63-year-old. with type 2 diabetes and hypertension, but also had a right foot ulcer with osteomyelitis, also underwent below knee amputation, and the wound cultures grew methicillin-resistant Staph aureus infection, MRSA for short. Patient has been on long-term antibiotics like Zosyn and vancomycin, and creatinine had gone up recently. So they were worried about like a drug-induced interstitial nephritis. So they did the biopsy on this patient, and what we saw was, this doesn't particularly make you think of diabetic nephropathy. That's a glomerulus with full of cells. All these ones which are multilobated nuclei, these are all neutrophils. When you see so many neutrophils on the glomerulus, we call it an exudative feature. And on a silver stain, you could see the mesangial sclerosis and early nodularity there. So there was some mild underlying diabetic nephropathy, but there's something else happening. And when we did the IF, there were lots of deposits in the mesangium and some along the capillary wall with IgA, C3, kappa, and lambda. And in this particular instance, we called it a diabetic nephropathy plus IgA dominant infection associated GN. So on EM, we were able to see some deposits here. So this is all the mesangial sclerosis you would expect, but these are the electron dense deposits that we saw on IF. And this is a particular entity, kind of seen in diabetic patients because of two things. The staph infections they have the super antigens will elicit this massive immune response. And then the diabetic patients also tend to have this high IgA-rich immune responses in circulation, especially if they have a diabetic complication or end organ damage. And so these two together will result in the deposition of this large amount of IgA deposits. And so some of the features, not to go into the detail here, the key here is if the patient is diabetic and has a staph infection and has some exudative features on the glomerulus, we are thinking about this entity. And other things that might be helpful will have low complement levels and so on. So this is one more thing that we think about. Just wrapping up in 2 minutes that, conceptually, we are thinking about the diagnosis of diabetic nephropathy. There are various components here, and here at the bottom is the number of years with diabetes. And this timeline is probably best applicable for type 1. As I mentioned before, but it kind of gives you some idea of what to expect in a type 2. And you can see the hyperglycemia is all over, cellular injury we are seeing with mesangial sclerosis and tubular atrophy and fibrosis, and then albuminuria, which is progressively increasing. And then the GFR tends to be high early on, and then it becomes low and ends up in end-stage kidney. Hypertension is increasing as time goes by. And of course, the cardiovascular infection risk is high, and the kidney complications will progress. So in this entire SPEC model we are thinking about, we are kind of the keepers of this type of mesangial expansions, interstitial fibrosis, and inflammation. But while we are looking at it, we are keeping in mind all of these things, the entire spectrum of changes that are expected. With that, in a pathology report, we are talking about diabetic nephropathy. We describe it and talk about the severity of glomerular lesions. And then if there is any non-diabetic kidney disease, and then we give a description of it and a severity, and that is a whole set of things that can be seen, as I've shown you. And then we also try to say how many percentage of glomeruli are globally sclerosed, how many are segmentally sclerosed, how much tubular atrophy and interstitial fibrosis there is, and how are the arteries and arterioles. So these are all the components of the pathology report that you would be seeing. And with that, I think I'm going to end, and I'm happy to take any questions. Let me see the chat.
Okay, thank you very much, Dr. Kambham, for a fantastic overview of diabetic nephropathy and some really beautiful pictures as well. So yeah, thank you very much. So we do have a number of questions in both the chat and the QA, so I will go through those. We may not be able to get through all of them in the next 4 minutes, but this presentation, I forgot to mention at the beginning, this presentation is being recorded. So so if anybody has to log off early, the answers to these questions will be available on the RPS website shortly. So I'll maybe start with the Q&A section. So the first question, in some patients with stable diabetic nephropathy for a long time, we find rapid deterioration of kidney function over a short period after long periods of a stable course. Do you have any explanations for that?
I don't think from a pathologist perspective, I have a good explanation for that. The things that I would be looking for is there like a ATN, acute tubular necrosis, or interstitial inflammation causing the progression. But I totally agree with you that the thought process here is there are certain patients who kind of hang along and then suddenly deteriorate. And that's perhaps as a point, the tipping point where the compensatory mechanisms are no longer helpful. I think that's a simplistic version, but other than that, I don't have a good explanation.
Yeah, that's my sense as well, that people kind of reach the end of the cliff and then their compensatory mechanisms drop off. Okay, I think you did touch on this, but if you have anything to add, when would you recommend a kidney biopsy in patients with diabetes mellitus?
Yeah, so I think there are atypical presentations that would prompt the kidney biopsy. Like, for example, I said if there is a sudden deterioration of proteinuria, the patient has like a 1 gram and now suddenly has 5 grams or 10 grams, that would be an indication. Similarly, a sudden deterioration of kidney function, or if they have significant amount of hematuria or RBC casts in the urine, or some serological studies turn out to be positive like an anchor. So some of most of them are clinical indications. It's beyond, and then the patient doesn't have diabetic retinopathy, but seems to have nephrotic syndrome, so that doesn't fit, and so on.
Okay, thank you. Somebody's just asking about the link between diabetic nephropathy and diabetic retinopathy. Do you have anything to comment on there?
Okay, so I don't know the studies linkage, but my understanding is that they're both markers of end organ damage, and when hyperglycemia or hemodynamic injury is happening, it's happening across the board in all organs, and I think they kind of diabetic retinopathy, in some instances diabetic neuropathy, and nephropathy are kind of the markers of end organ damage, which are you can assess. So that's my understanding.
Okay, I apologize to whoever wrote this. Just a request to use the laser pointer instead of the cursor, I guess. Yeah, sorry, I missed that until I dropped the ball on the moderating duties there. But yeah, for what it's worth, I thought the cursor was visible throughout. Okay, next question is, if there's diabetic nephropathy with other lesions like FSGS or IgA, how can we conclude the predominant, or I guess the primary diagnosis, as the treatment will obviously depend on that?
Yes, absolutely. So this is something I didn't really touch upon. When we have more than one entities, we are writing a comment about what we think is the predominant process. So that can help guide the therapy. Like, for example, let's say an example of diabetic nephropathy and minimal change disease. When can I make both diagnoses? I can confidently say that if there is mild diabetic nephropathy and the patient has nephrotic syndrome, and the podocyte food processes are diffusely effaced, then I can say there are two entities and minimal change disease needs to be treated. But on the other end of the spectrum, if it is a advanced diabetic nephropathy with podocyte nephrotic syndrome and podocyte effacement, that doesn't really help me. Even if you tell me that there seems to be a rapid progression of proteinuria, because I think in a advanced nodular glomerulosclerosis, there's always associated podocyte injury. And so I would back off from giving two diagnoses. Let's say FSGS, for example. And again, FSGS also kind of follows similar rules. If it's a milder degree of diabetes with a lot of segmental sclerosis, especially the ones which look like cellular features, and with podocyte hypertrophy and hyperplasia, then I would feel confident saying that maybe there might be a superimposed process. And of course, especially if the podocyte food process effacement on EM is pretty advanced. So I would, I think, although there are newer studies showing that FSGS lesions, if a lot of extracapillary hypercellularity is there, that may be poor prognostic indicator for diabetic nephropathy. So are they two entities, or it's just that the diabetic nephropathy triggered a podocyte injury, which just was ramped up and went off in an aggressive direction? So it's hard to know. So yeah, so this is like, sometimes I can't tell, and if I can't, I will say so in the report. But as much as possible, we'll try to tease it out. And in terms of diabetic nephropathy and IgA, it's the same thing. If I have very few deposits without endocapillary proliferation and the diabetic nephropathy is severe, then I feel comfortable saying that maybe the IgA is incidental finding. So I think it's and from that point of view, it's important to know the lesions, variety of lesions you can see from early diabetic nephropathy to advanced diabetic nephropathy.
Great, thanks. Next question, and we are past the hour. I just want to confirm that you're okay to go.
Yeah, that's fine.
For a few more minutes. Okay, all right, thank you. Because I think this is a very valuable portion of the session, and people are obviously interested in getting your feedback and opinion on these various issues. So next question is with regards to distinguishing Kimmel-Steele-Wilson lesions from idiopathic nodular sclerosis. Are there any, I guess, morphologic clues that you are aware of that help differentiate between diabetes and non-diabetic forms of that histologic pattern? There's nothing I'm aware of.
No, not that I'm aware of. Earlier studies looked at CD34 staining and tried to identify this increased vascular channels in the nodules. But I know subsequent studies have shown that even in diabetic nephropathy. So in my mind, I don't think you can tell the difference.
Yeah, that's my experience. Yeah. Okay. Can medications to treat diabetic nephropathy, such as RAS blockers or the SGLT2 inhibitors, do you know if they have any effect on histopathology or the findings we see on biopsy?
I don't think we know, but I think if you look at some of the epidemiological data on diabetic nephropathy, it's possible that we will see a slightly different phenotype over the next few years, especially because they're using more and more of this SGLT to block it. Yeah, so it's too early to know, but I think there is some epidemiological data showing that the diabetic nephropathy severity may be less. But this will take another 10 years before we see the difference, I think.
Yeah.
And if anyone else know additional information, please chime in. I'm not aware of any studies showing the difference.
Just keeping an eye on the chat as well, and I don't. Everyone else is muted, so if anyone has any input, please enter it into the chat. I don't see anything, but yeah, I'll keep an eye on that as well. Okay, someone just put recurrence post kidney transplantation. I mean, obviously you can get recurrent diabetic nephropathy post transplantation, so I'm not sure if they're asking like what the recurrence rate is. I don't know, any comments you want to make with regards to that?
I think, so one thing to remember is that while the matrix is getting deposited in the kidney, the body is trying to lyse the matrix also. So when there is a transplantation happens, especially if they have a pancreatic transplantation, I would think there can be regression of disease. And similarly, if post-transplantation, if there's a combined kidney and pancreas transplantation, I would think the recurrence rate would be much less. I think it depends upon the glycemic control post-transplantation too.
Yeah. Okay, next question. Is there an explanation for the IgG and albumin linear deposits seen in IF?
No good explanation except that the advanced, I had some of the text, I removed it. I just thought it was too much text. But anyway, so the idea is that the advanced glycation end products kind of bind to all the tissues, including basement membrane. And there is some physiological changes, pro-inflammatory, pro-fibrotic changes that happen. And in all this remodeling that is happening, these plasma proteins are probably entrapped, or at least that's the explanation that I've read. But sometimes it can cause confusion for anti-GBM disease. But typically seen with IgG and albumin, but to some extent kappa and lambda as well.
Okay, kind of a related question. When you're trying to decide whether something is essentially a linear IgG pattern related to diabetes or a true pseudo-linear IgG deposition related to an immune complex disease, any, I guess, advice or, any?
So I would say you have to be extremely careful. Reassess your impression after every modality by light IF and EM. So I guess, if you see it with both kappa and lambda, that's kind of helpful because light chain deposition disease, you will see light chain restriction. And the other thing I've found useful is that typically you don't see prominent linear staining in the vascular basement membranes, but I feel the light chain deposition disease, the vascular basement membranes are brightly lit linear patterns. So that's something I kind of use as a soft feature.
Thank you. The next question is, does anyone know how capsular drops form? So going on, for capillary loop insedative lesions, I assume the insedate comes from the glomerular capillaries, but it's not clear for a lesion associated with Bowman's capsule. The source could conceivably be filtered protein or something coming from peritubular capillaries. Do you have any insight on that?
I think I can't, don't quote me on this, but I vaguely remember that the insedative lesions are probably coming from the vascular pole and they're tracking along the Bowman's capsule. And same way they can track down along the tubular basement membranes as well. So I think these are just coming from near the vascular pole. Of course, you probably can see segmental sclerosis with Bowman's capsular adhesion potentially could give that too. But the true capsular drop in my mind is probably like tracking from the vascular pole.
Yeah, I think that makes sense. Okay, next question. I guess acknowledging that there's always a risk of, or there's always the possibility that there's light chain or heavy chain deposition disease concomitant with diabetes. The question is, should all patients over 50 years have an SPEP done?
I would think so. I think, I mean, you can't control what's being tested. My recommendation would be yes, the nephrologist should probably look for SPEP and UPEP. But from a pathologist perspective, I think we can only assess what we have. And from that point of view, I would say kappa and lambda light chains. And of course, there could be IgG heavy chain deposition disease too. So yeah, so EM is important in that instance. It'll be useful. Even if, so there are instances where the patient can have SPEP, they see some monoclonal spike, but that may be unrelated to the kidney presentation too. So that's another instance where you can't just rely on the clinical SPEP and UPEP.
Okay, thank you. All right, a few more to go here. You're still okay to keep going?
Yeah, that's fine.
Yeah, okay, all right. Sorry, the next one is, do you think that all diabetic patients should undergo renal biopsy irrespective of renal manifestation to identify early renal involvement?
I don't think so. I think there is it's probably a little, I would not recommend doing biopsies on all patients. If you were to do that as part of a clinical trial, then we all, the renal pathologists, would love to learn about the early changes of diabetic nephropathy, and perhaps we could quantify that and come up with a template rather than focusing on the late stage diabetic nephropathy changes. But from a patient perspective who's not on a clinical trial, I would say no, there should be an indication for a biopsy.
Yeah, I would agree. Okay, this is next question is not related to diabetes specifically, but I think because you mentioned it, what is the explanation for predominant lambda deposition in IgA nephropathy?
Okay, so I've always wondered about that. I actually use that in my diagnosis, in differential diagnosis, as a helpful feature.
Yeah, me too.
But I don't have a good explanation. If anyone else has it, please type it.
Yeah, if anyone, I don't know. And we did actually discuss this during the IgA talk with Tony Chang, and yeah, I don't think anybody has explained that yet. But if anyone knows, please enter it into the chat. Okay, next question is, how do you define diabetic changes when associated with other diseases like minimal change disease?
I think we kind of touched on it.
Yeah, I think you covered that. Yeah. Okay. So next comments, Neeraja, great talk. Thank you very much. Do you have any thoughts why some patients develop diabetic nephropathy a few years after the onset of diabetes, but some may have it for many years without morphologic changes?
Yes, I think there is probably some genetic predisposition. Definitely the diabetic nephropathy seems to occur in families. There are other families who don't get diabetic nephropathy despite not so great glycemic control. There are actually GWAS studies looking at the specifically diabetic nephropathy, not diabetes in general. I don't think we have consistent results across various studies, but there is I think people know that there is some predisposition beyond just glycemic control to develop diabetic nephropathy. That's the only answer I have.
Okay, thanks. So yeah, we talked about how you can see an FSGS pattern with these patients. Somebody specifically asked if you can see collapsing glomerulopathy accompanying diabetic nephropathy. I've never seen it, but have you encountered that?
Yeah, I think we see sometimes, especially in more advanced diabetic nephropathy, and often the ones who have more arterial or hyalinosis. I think in that context, the collapsing glomerulopathy is ischemia related, rather than primary podocyte driven. So again, it depends upon the clinical presentation as to what I make of that collapsing change, quote unquote collapsing change. But yeah, you can see kind of a collapsing FSGS in diabetes, advanced diabetes.
Okay. Is it possible to suspect diabetic fibrillosis without EM?
I can't. I can, but I can't. Yeah.
Yeah, I think that's fair. And a practical question: how can we differentiate Kimmel-Steele-Wilson nodules from an amyloidosis nodule?
Great question. I had some slides. I removed them because I just didn't want to go too far from diabetes. So amyloid, I think our stains, even before you go to IF and EM, the stains are very helpful. The amyloid, for the most part, the mesangial expansion, mesangial area tends to be very pale on PAS, and silver stain negative, and some grayish color on trichroma. That one I'm not always convinced, because I think it depends upon the quality of the trichrome stain. But the PAS and silver stains are very helpful, whereas in diabetic nephropathy, the mesangial nodules are bright pink on PAS and black on silver stain. So those are the things that are helpful before you go to the IF. And IF, you will, depends upon whether it's amyloid A or kappa or lambda, when you could see smudgy staining in the deposits. And EM, of course, I think the fibrils are pretty characteristic, and the thickness of fibrils is very useful for amyloid, 8 to 12 nanometers, whereas diabetic fibrillosis is much thicker, and it's often seen in the mesangial area. In most patients, it's probably around 16 to 20 or so, but the IF would be completely negative in diabetes, other than the linear staining.
Okay, and just a couple last questions in the chat. So there's this one talking about the thickening and duplication of the tubular and glomerular basement membranes and Bowman's capsule, I guess. So these changes in the basement membrane, are they specific to diabetic nephropathy? Yeah, I think that's the main question.
Yeah, so you know, that's one of the earliest features you will see. It's not specific. Those early changes, what we call diabetic nephropathy, can be seen in chronic hypertension too. So there are instances where the patient has diabetes and hypertension and you see some early changes. I kind of refrain from calling it diabetic nephropathy outright because those early changes can be seen in both. Which one is contributing to that, it's too early to know. So I kind of put that thing in there as the earliest changes observed in diabetic nephropathy, but no, I think if I just had a basement membrane thickening, I wouldn't label the patient as diabetic nephropathy, not yet.
Yeah, I would agree. Any significance to the diameter of the glomeruli in diabetic nephropathy?
Clearly, the early diabetes, early stages of diabetic nephropathy, there is glomerular hyperfiltration and hypertrophy of glomeruli. So they will be enlarged. It's a very well-known thing. And then as it progresses, there's, again, it stays enlarged, but there's more and more matrix getting deposited. So yeah.
Okay, and one last minute question has come in through the Q&A, so I'll cut it off after this one. But what criteria do you use to diagnose primary podocytopathy or FSGS in nodular diabetic nephropathy?
I think this is, again, you know, boils down to how bad is the diabetic nephropathy. For me to confidently say that there is primary podocytopathy, the diabetes has to be milder, the patient should be fully nephrotic, and there should be extensive food process effacement. That's one I would put as a two separate diagnoses. And short of that, you know, and if it's both of them are like equally present, if it's, I kind of like talk about it in the comment section, and those are the cases where the comment is going to be long. Yeah. So I think I think that's all I had. I touched on that earlier.
Yeah. Okay, well, thank you so much again for your time and for the excellent presentation and for handling all these questions. And thank you to the participants for your involvement. It's great to see so much interest from our renal pathology community. So just an announcement that the final scheduled lecture for this series at this point is Dr. David Howell will be talking on May 28th, same time as today, on the performance and adequacy of renal biopsies. So that is our next scheduled webinar. So again, this will be posted on the RPS website within the next week or so, and please fill out the survey that we will be sending out later. So thanks again, everyone.
Thank you very much for this opportunity. Bye. Thanks, Ben.